Thank you for inviting me to talk today about two of my favorite topics, menopause and patient advocacy. So, wow, it's nice to kind of marry the two together. As I said, I have about maybe 20 slides to run through, so plenty of time afterwards for questions. And along the way, you'll see all of the pictures in my presentations are, most of them are my pictures. A couple of them are my daughter's from some of her travels, but a lot of flowers. So you'll kind of get that theme. And actually at the top of this one, you can see already, this was a special tulip I walked by on my daily walk back in the spring. And every day it was changing. I thought like, oh, this is interesting. So I took a bunch of pictures. And then, of course, toward the end of this tulip's life, I thought like, oh my goodness, I'm documenting menopause. But that's a joke. I think we have to remind ourselves that nature sometimes imitates what we do and vice versa, but we are not flowers. So here we go. Let's talk about, first of all, the basics of menopause and perimenopause. I will kind of toss in a few juicy topics. We'll talk about system challenges, what the medical profession needs to improve. And also how women can self-advocate and how we can advocate for them. At the end, I'll have a few resources that are just kind of willy-nilly, not like a Bible, but truly perhaps might be interesting for those who want to learn more. So a little bit about me. I missed the intro, but I think you know that I've been a physician for many years. My degree first was in architecture and urban planning, so a little bit different. And studied and trained and live in Seattle. So I was at University of Washington School of Medicine and have a degree in internal medicine. Practiced clinically for 25 years, quite a long journey, and then peeled off about 4 years ago and started my own business. Along the way, I had a lot of different hats that I wore administratively and just clinically as well. I developed a program called Menu for Change, which was a weight management wellness program. Early pandemic years, I developed my website, Menopause Menu, which was really for fun, but then turned into a really kind of like a platform upon which I then wrote my book, which is the Menopause Menu. And then my business, My MD Advocate, was really a way for me to still function as a physician, but to do it in a different way and to be of better service to people. And it's really been a pleasure to kind of work for myself. I guess that's the best way. My latest adventure is something called Voices with Vigor, and it's been kind of a hoot to host my own talk show. You'll be able to learn more about that later. But it's just nice, again, to kind of weave the threads of my life tapestry and kind of join these things together in ways that are meaningful to me. This is a picture, by the way, of me taken by my daughter in Cypress Gardens, which is near Charleston, South Carolina. We were there in June to visit her. She's now not in South Carolina, but gorgeous, gorgeous moment. We had just seen an alligator. I was a little nervous being that close to the swamp, but it was just breathtaking to sit there and kind of meditate and just experience this very different environment than what I was used to. Thinking about environments that not all of us are used to, let's think about menopause just briefly about the basics. So most people know this is 12 months after your last period, boom, you're in menopause. There's a word that's very, very important to know, which is perimenopause. Peri, think about peri or perimeter. And so it's a time frame usually leading up to menopause, and it can be different for every woman. It could be a matter of months or it could be a matter of years. And I'll come back to that in a little bit as well. There's early or premature menopause, which is long before you typically, in terms of an age range, expect menopause. And that could be due to a variety of different things. You can think about surgical removal of the ovaries. You can think about someone who's had treatment for cancer, perhaps maybe chemo or radiation, so the ovaries are shut down, or just premature ovarian insufficiency, which is a whole nother category. And then there's post. Post means after. So postmenopause is all the years after menopause. And frankly, once you're through menopause, you are postmenopause forever. And so that's something to keep in mind. I will put a plug, so a community service announcement or CSA, that any postmenopausal bleeding is never normal. And that's really key for everyone to know. So I can't tell you how many times I've had patients who were perhaps in their 60s or even early 70s, and they say, oh, I had a period the other day. That was weird. It's like, no, not a period. That's bleeding. That's not normal. Got to check it out. So there are many, many, many physical symptoms of menopause. There are many psychological and emotional changes. This is midlife, right? What happens during midlife? A lot of things are going on. And a number of my colleagues will kind of tout menopause as puberty backwards, which, it kind of sounds funny, but in some ways, maybe it is in terms of hormonal fluxes and changes. But I would say when you think about puberty, you think about childhood or preteen or early teens. And yeah, they're not necessarily wise beyond their years. So I think of menopause and the transition through menopause as kind of garnering wisdom and coming into your own in many ways, which is definitely not puberty. You can think about it young, old, it doesn't have to be so polarized. I think actually this picture is of the allium plant, which is giant onion, and there are lots in our neighborhood. They're very, very large. And I think the old ones are actually stunningly beautiful. Maybe they're not attracting the honeybees as much, but dry flowers last forever, right? So they're still gorgeous. Let's briefly talk about some common symptoms. Again, this could be a 5-hour talk about symptom management, but I kind of gloss over some of the common ones that bubble up. And obviously, hot flashes and night sweats, those are kind of the hallmark. Not every woman gets them, so lucky them. But some will have hot flashes that last for many, many years. I mean, I'm in my 60s and I'm still getting some night sweats. So there are ways to cope. There are ways to deal with them. We can talk about hormones in a minute. But those are very commonly the kind of the herald sign. Vaginal dryness or irritability. Think about thinning of the lining. Those can lead to UTIs, urinary tract infections. Very, very frustrating for many women. There's some women who never had UTIs. They go into menopause, boom, it's just kind of a hallmark. Along with that comes maybe changes in libido or sexual desire. Sleep, yeah, trouble falling asleep. I would say that's probably, in my mind, one of the most challenging things to navigate. If you're not sleeping well, we all know it's just almost game over. One night we can always manage it, 2 nights maybe, but if week after week after week you're not sleeping well, it just bubbles up into everything. It affects brain fog, focus, it affects your mood, it affects your ability to navigate life. So it could be sleep quality, not just quantity. So if you're waking up a lot and frequently, you can be in bed for 9 hours, but if you're constantly waking up, that's really troublesome. And then, of course, waking up early, which is a real bugaboo for some women who just say, like, I pass out at night, I sleep, but then I wake up at 3 a.m., boom, I'm awake, and I'm not ready to start my day at 3 a.m. So that's an issue. Weight, oh boy, that's huge. Weight gain is not infrequent. And that, of course, links very much to body image, which, whether we like it or not, how we look at ourselves in the mirror does impact kind of our mental psyche. And honestly, I think that we need to get a bit more compassion. Many of us have compassion for others. We have to learn that self-compassion when we think about our own body image. And then I mentioned mental health before. There's so much stress in this time of our lives. When you're in your 30s and 40s and 50s, what's happening during this time frame? Well, many people, many women are experiencing shifts in their family structure. Maybe if they have kids, maybe they're suddenly empty nesters. If they're married, or maybe they're divorced or remarried, or maybe they're single, there's shifts in how their relationships are happening. Many are caring for or have cared for adults in their family, be it brothers and sisters, perhaps parents. There could be death in the family. There's so much going on, and I think it's just ironic. Maybe is not the word, but that's piled on to the fact that our hormones are changing, and we're having to navigate all of these body things as well. So a big mixture there. So let's talk about hormones. I didn't put this as the first slide. This is, I think, slide number 8, because I never want to think about menopause discussions as just about hormones. But I think it's important, honestly, nowadays to really kind of put balance to the internet craze, which seems to be touting hormones for everything. If you have a sore toe, oh, go on estrogen. If you have itchy ears, oh, take hormones. That's craziness. There's some really, honest to goodness, great benefits of menopause hormone therapy. And I think the top few that are evidence based are prevention of urinary tract infections, absolutely, improvement of sleep, and that's typically because it's reducing the night sweats, but there are other mechanisms. And then, honestly, a little less difficult to measure, but enhancing the quality of life. They should be considered in terms of when you think about your bone health and prevention of osteoporosis, but they're not the first line treatment. So if you have someone who has borderline osteoporosis, maybe osteopenia, which is like they're going to be at risk for osteoporosis, then you don't say, oh, hormones are the treatment unless there's some other reason that you should be on hormones. So there are many other medicines for osteoporosis. And to the best we can tell, menopause hormone therapy does not significantly change the risk of stroke and heart disease or breast cancer. Now, that's really important when we think about that initial data way back about 20 years ago when the Women's Health Initiative came out. And it was looking at, oh gosh, I remember actually being in my office. Women would call up and say, like, oh my God, I was told to stop hormones and now I'm going crazy. And these are women who are 65, 75, 80, and they've been on hormones forever. So thank goodness we've had more of a review and a modern approach to interpretation of this data. And thank goodness there's no kind of cross to bear now. So oral estrogen does have risk for clots. So whoa, we can just go to transdermal, go to an estrogen patch. In fact, the most common combo is a Mirena IUD. So that's a progesterone IUD with an estrogen patch. So that's kind of like the lucky charm. But again, I think that we have to be discerning about hormones. It shouldn't be in the drinking water, but it's definitely nice that we're in an era where that can be considered for many, many women. I put in this slide because my daughter just came back from a trip to Japan and paid a visit to the snow monkeys in outskirts of Nagano. And oh my gosh, looks like they're, I know that's a hot spring, but that's a good way to cool off, right? Or maybe to warm up. Okay, let's jump into system challenges. And I take a deep breath because there's so much going on in our healthcare environment nowadays. Most people, and I even use this mantra, I think, the health systems are broken amongst many other things in our country. So I think there's so many things that make me sad or that make me aggravated or even angry. And it's maybe good to pull out some of this because this really forms the basis for how we can better advocate for others and also advocate for ourselves. I think it's kind of a statement of the obvious that we're really in an era that is polarized. I mean, you think about politics, you think about world economics, just everything. And I think that that does a huge disservice to helping women navigate this era because, there's no need to take sides. It's not all or none. It doesn't have to be evidence-based versus holistic. There could be kind of a nice mixture of all of that. And I think that's important. The pendulum swings, as we know, the extremes. I mean, I guess that's really the perfect way to describe what happens with the Women's Health Initiative data. So at one extreme, oh, hormones are evil, they're terrible, they're going to kill you, they're going to cause cancer. Well, now, unfortunately, I think it's like, oh, everyone should be in hormones. In fact, I think there's almost reverse gaslighting going on. So if you're a woman and you're not on hormones, why aren't you? I think that's ridiculous. Let's come back to the center. Let's think about the pros and the cons. It is an option and it should be an option for many. But there's the underpinning of this is I think there's a huge distrust of physicians in this current healthcare world that we're in. Call it the pandemic. I don't think it was just because of that, but that probably made things worse. People were angry at access, lack of. Insurance companies are not helping. Just kind of the corporatization and the consolidation of healthcare is not helping. And so I think it's causing a sense of angst for women trying to get good information and not really trusting perhaps that what they're getting is what they need or that people are taking the time to listen to them. There's something that I guess I have to mention because it's on my mind, but as a physician, I'll have patients come in, oh, I've done my research. Um, you know, for 32 years, I've been a doctor. I have never started a conversation with anyone saying, oh, I've done my research. I think it just automatically makes it polarized. It makes it like they don't want to even have a conversation, because what the physician hears is like, wow, this person doesn't need me, and they're not interested because they've, quote, done their research. And that's a slippery slope. If you go online, you can find anything these days. There's a really good study you should look at sometime, and I think it was from the British Medical Journal, BMJ, 2018, and I call it the parachute study. But basically, it was really incredible how they wrote this up and submitted it to get published. It was a randomized controlled trial of the use of a parachute to prevent death and major trauma when jumping from an aircraft. You think like, well, duh, a parachute is going to save you if you jump from an airplane, right? Well, the conclusion was, quote, parachute use did not reduce death or major traumatic injury when jumping from an aircraft. And you think like, this doesn't even pass the sniff test, right? Well, if you used AI to search for this, that's the conclusion. Well, guess what? If you actually read the study, which means several pages looking at the method, what was the study design, how was the data analyzed, you'd kind of eventually see, and a picture certainly was worth 1,000 words, that the study showed a woman with a parachute on her back, looked like a backpack, jumping out of an airplane, and it was a biplane on the ground, and she jumped basically about 4 feet. So, yeah, I mean, it's like a tongue in cheek, it was a satire. But this is the dilemma, I think, is that people will look for something, and the first thing that pops up on their search is going to be AI summaries. And is that really accurate? Is that really evidence based? So just keep that in mind. How do we get information? How do we search? I would say the social media influencers are not helping, nor is probably half of Hollywood women who, are going through menopause and touting all their pills and potions. Just beware of snake oil. I think that's just kind of my go-to phrase. And another picture from my daughter when she went to Iceland last summer. This looks absolutely gorgeous. Well, what does the medical profession need to do? How can we improve? I put at the top of my list whenever I talk about the subject, listening, using our ears, listening to women. I think that doesn't happen enough. There's no time for conversations. And things get kind of compartmentalized. And as I said, kind of there's the gaslighting. I think we need to really bring that pendulum back to the middle, personalize care, look for ways to strategize. Where's this woman coming from? What are her goals? What are her belief systems? And I think that would go a long distance to being a better service and maybe rekindling that honest to goodness, good doctor-patient relationship. I think testing is something to reconsider. And what I mean by that is many will come in with their, patients can order tests on their own nowadays, and they come in with long printouts of blood test results, and they just want them interpreted. That's not a good rapport with your doctor. On the flip side, many times a doctor will order a test just because it's something to do, but is it really helping? And I will emphasize this point that when you're going through menopause, you rarely need a blood test to prove it. Think about it for a minute. If you have children, if you have a child and they went through puberty, they're probably 12 or 13, perhaps, maybe a little younger nowadays, you don't need a blood test to prove puberty. Well, rightly so. If you're 48 years old and your periods are skipping around, you're feeling hot flashy, you're brain fogging, and you just kind of, things don't feel right, you're in perimenopause. And if you've gone, 6 to 8 to 9, then 12 months without a period, and you're in that, proper or typical age group, you are going through menopause. You don't need blood tests to prove it. And I think that's one of the biggest industry failures because they're convincing everyone, check your levels. Well, if you check my hormone levels, maybe not me, but someone who's going through menopause today, they're going to be different tomorrow and the next day. So that one moment in time is not going to kind of solidify a diagnosis or a care plan. So again, reconsider how testing is used. And then lastly, honestly, I think that we need to move away from silos and lanes. And what I mean by that is I remember talking to an orthopedic surgeon and talking about frozen shoulder and why that may be more frequent during early menopause or menopause. And she said, "Oh, well, yeah, I'm an orthopedic surgeon. That's, I have nothing to do with that." I think, like, okay, that wasn't helpful. Or the flip side, as a patient coming in, maybe they're in the ER and they're getting evaluated because they have palpitations and they're anxious and, they want to make sure they don't have any heart problems. Turns out in retrospect, it's all perimenopause. But they even perhaps bring up the fact that they're, 51 and could this be hormones? And the ER doc maybe is like, "Oh, well, that's not my thing. I'm just making sure you're not dying from a heart attack." Well, that's probably true. But again, if we can kind of stop this separation, I think that will go a long ways towards validating. So thinking about perspective of how can women self-advocate? This is where I love to talk about strategies. So if you're a woman and you're getting ready to see your doctor, prepare for that appointment no different than if you're preparing for an important meeting. Because, guess what? You wouldn't show up to an important board meeting or a meeting at work late, like you overslept and you rush in, you don't have your notes, and oh my gosh, I thought of 5 questions, but where are they? And scroll through your phone, see if you can find them. No, you come in, like, think about power moves. You have like a one-page, single side page if you're printing something out. Bullet points, be crisp, be clear. Maybe think about 5 or 6 or 7 or 8 or 10 things, but maybe know that you're only going to cover maybe the top 2 or 3 because you may not have time for that. Be organized in your approach. And I think that that's where, unfortunately, it then crumbles into a system problem. If you're coming in and you're forgetting that, oh my gosh, we just talked about 3 things. My doctor's walking out the door, but I totally forgot to mention I have vaginal dryness. Oh my gosh. And then, of course, when the door's being opened, then there's no privacy. And then, of course, you forget about it. So, again, structure your thoughts, go into it like a meeting. Don't apologize for asking questions. This is your time. It's great if you have extra time. So, that's always nice to ask for, but you may not. But let's say you have 15 minutes. Think about, okay, what can we cover in 15 minutes? And then go for it. Don't say, "Oh, I'm just really sorry to bring this up. I know it's a complex topic." No, bring it up and let them kind of partner with you in terms of how they answer it. Suggest a follow up. Here's that vicious loop, which is really frustrating. So you go to see the doctor, have a good conversation, they're listening to you, and they say, "Oh, well, let's check a bunch of tests, blood tests." You leave, you go to the lab, donate your blood. A week later, you get the results. And voila, guess what? They're basically normal. Now you're thinking, okay, wait a minute, they're normal. What do I do? So then you type in the portal, like, okay, well, we talked about this. I had all these other issues that we were waiting for these results. What's my next step? Well, that's where things fall apart because then perhaps the doctor's on vacation. There's someone covering for them. Or maybe they don't do their portal messages because they're overwhelmed and they don't have the time. So then their staff person, who's not someone you talked about with your intimate discussion, they get in on like, "Well, you could go see so and so," and they did put a referral in. Wow, referral is not necessarily care. So you feel like almost you wasted your time or like you get frustrated. So learn how to channel those frustrations. Is it a system problem or is it an individual problem? I have patients who used to complain bitterly about the fact they couldn't find a spot in the parking garage. Well, oh my gosh, don't take it out on me. I don't control the parking garage. So again, be structured, have a goal, have more than one goal, write it down and make sure there's a follow-up plan because then I think you're going to have the most success for feeling like you're being listened to and that your concerns are being validated. This is a picture I snapped on a recent trip to Denver, and I was advocating for myself going to Denver for some medical care. So it's really a beautiful October day. So if you are advocating for someone else and you're trying to support a woman who is going through perimenopause or menopause or just dealing with women's health issues, what are some good tips to think of? The first thing I thought of actually when I was making up these slides was sharing your story. And, sharing stories is how we connect to others. I mean, I do that a lot, but pause for a moment, hit the pause button on that. I think an example would be if you are diabetic, it doesn't mean you are an expert on diabetes. So put your own history aside and kind of bring that person, make them in the forefront. So just because you think about menopause, if something happened to you or didn't happen to you, doesn't mean that's going to be the case for someone else. So don't kind of make your story their story. It's important to learn more about health literacy. So, personal health literacy is the ability of an individual to find, understand, and use information to make healthcare decisions. I was actually doing a little bit of research, and I think in 2023, it was estimated that only 12% of adults in the US have proficient health literacy skills. Oh my gosh, 12%. And then if you add in what's something called e-health literacy, so that's the ability to seek, find, and understand and kind of absorb health information from electronic sources and apply that knowledge to addressing a health problem. If you add that in, it's kind of a mess. So keep in mind that health literacy is important when you're thinking about working with someone. I believe we talked about the polarizing views and reverse gaslighting, but keep that in mind. You don't want to it's not all or none. It's not on or off, hot, cold, yes, no. There's so many nuances when it comes to menopause. Get those listening ears up. Run away from those who are just marketing and peddling their own supplements and potions. Listen to my spiel because you need to buy my book. That's never how it should be. And again, when you're advocating for someone, be wary that even though there's someone who is an expert perhaps in their field, if they're telling you to buy their gummies, their evening gummies or their hormone creams, step away. And then, let's kind of minimize the metrics. I think they're overused, yes, as physicians. So many are working companies or corporations where they have to check the boxes for caring for patients. But if we advocate for someone, if we can step away from that box checking and really focus on caring for someone, I think that's much more important. And again, I always say take time to listen. That is really essential. And Donna, you were mentioning that, you and Heidi and I met up. This was a little over a year ago. Remember that picture? I remember that evening and that gorgeous, gorgeous moonrise. It was so stunning. What a day. And actually next to me is Diana Londoño, who's a urologist from LA. Next to her is Heidi and then Donna. So that was fun times. On the stage, I was next to two Connecticut physicians, retired family practice doctors. And then the questions were asked off to the left there. That's by Tara Bano. She worked for Staten News. So good times. I wanted to throw up a couple of resources, and I almost didn't put this in because I don't want people to race to write these down. These are not the Bibles. These are not like must reads, but they were just kind of what were in my mind when I was thinking about this subject. So there are a few websites I think that are reasonable to look at. The Menopause Society, which used to be called the North American Menopause Society, or NAMS, but now it's called the Menopause Society, has a portal which is useful for patient information. It's also useful for physicians. I'm actually a member of the Menopause Society, but I'm not certified. I didn't take any examination. Honestly, I didn't think I needed to be certified to do what I do. There's a nonprofit called the National Menopause Foundation, also very helpful. The Vagenda, which is a Substack written by Jen Gunter, Dr. Gunter, who's in Canada, is just a hoot, great information. And of course, I couldn't resist putting my own menopause menu website up there. Books, again, these are in no particular order, and you don't have to read any of them. But Jen Gunter has a book from a number of years ago called The Menopause Manifesto. I'm not sure I like the word manifesto, but hey, that's okay. I like her style. Vonda Wright wrote a book called Unbreakable. I think it's focusing on bone health and other things as well. Kelly Casperson, urologist, just came out with The Menopause Moment. She's a little on one side of the pendulum. Everyone needs to be on testosterone, so be forewarned. But she's great. And then, of course, my own book, The Menopause Menu. And then, there's so many apps and videos. I wouldn't say necessarily just about menopause, but they can be useful when you think about navigating menopause. And starting from the bottom up, honestly, Calm is a good one. Insight Timer is free. Evia is a hypnotherapy app I've never used, but sounds very interesting. There are lots of YouTube videos. I have my own channel, and then my Voices with Vigor talk show, which I will have one more slide up. Here we go. couldn't help but put a plug. This is a program I started back in August. It's monthly. I get three experts in their field. These happen to be three doctors on this one, and they're health adjacent themes. And the themes this month pertain to weight. So it's called Weight What. And Dr. Chrissy Ott in Oregon is fantastic. Megan Tierney in Washington and Franchelle Hamilton is a bariatric surgeon in Texas. And they're really intimate conversations. They're all free, they're all virtual, and they're all live. So check it out. You can go to my Menopause Menu website and click on Talk Show. I'd love for you to come. That's it. I did a lot of talking. I will just say these are my go-to places to find me. So the top is my website, my two websites. I'm on Facebook barely. I definitely do a lot of LinkedIn, and that's my fun YouTube channel. But feel free to reach out to me by phone or by email, and I'm delighted to talk with anybody. This last picture, I'll just leave you with this in your memory banks, is on one of my favorite walks. There's a big, huge park. It's massive, called Discovery Park, and this looks out. This looks west to Puget Sound, and this is several hundred feet up high on a large cliff, so you can't really get that. But looking down on the water, it was a blustery, cold day, and the wind was whipping up, so they're white caps, even though they look pretty small. They were quite large. And I never cease to be thrilled by walking there and just kind of let my mind wander and let nature help guide me.